Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, it's a pleasure to have everyone join us today for another episode of All Things Cardio-Oncology. And as usual, it's my pleasure to welcome my co-hosts, Dan Lenahan and Dr. Arjun Ghosh. And today we're going to be discussing CT and cardio-oncology with Dr. Juan Lopez-Mattei from Lee Health and Heart and Vascular Institute in South Florida. He's also the medical director of cardiac imaging there. So welcome, Juan. We're glad you could join us today.
Thank you. Glad to be here with such great figures in cardio-oncology. Thank you.
Yeah, and we in particular wanted to talk about the latest expert consensus between the Society of Cardiovascular CT, which has also been endorsed by ICOS. So we appreciate your work on that and the collaboration that we were able to participate with you on that statement. And I wonder, to get us started, if you could just talk a little bit about this initiative and how past work culminated in this document in particular. And also maybe just tell us a little bit about yourself and your background in CT.
Sure, absolutely. No, thank you. So I formally trained in cardiac imaging, under the aegis of Dr. Bill Sogby and Deepan Shah at Methodist, and I spent most of my life, so far after training at MD Anderson, about 9 years, and during my time there, I was not noticing a trend that we have discussed many times, cardio-oncologists and imagers, and it's just that you're seeing these patients, and then often they have scans that you can look at, like chest CTs for other reasons, and you will see some calcifications there. And there was an opportunity there to, knowing that presence of calcification in non-gated studies can be prognostic and comparable, to what we calculate with the calcium scores and the data we know from MESA. So basically, a group of us, imagers and radiation oncologists, believe it or not, and oncologists, it was a multidisciplinary group that I've come to know for several years, and having those stakeholders plus, the great members of SCCT, we came together and we decided to develop a document that could provide guidance to the use of cardiac CT in patients with cancer and survivors. And part of that is because we noticed that there was a significant gap in the recommendations regarding cardiac CT. The multiple guidelines which are great documents, very helpful clinically, but we felt that CT was not represented the way we wanted to, and we understood the benefits of it, and that's that spearheaded some collaborations too. So I started doing some work on calcium score in the pre-treatment scans, the planning scans for radiation therapy in the chest. So I did some work there, and also other people have done great work using AI to quantify calcium score in non-gated scans and in the treatment plans as well. So there's data certainly that supports some sort of increased risk, depending on the calcium score in these patients, the patients that are receiving radiotherapy, and patients also not receiving radiotherapy. But this is a very important thing that that we felt that there was enough data and concern to provide some guidance. And like anything in life, these documents, they have to be updated, and when they come out, usually we're behind, especially now that we have AI plaque quantification, which is something that we didn't really mention in the document, but I think that could have some value, the AI quantification of plaque in coronary CT. And I don't know, I feel that CT has grown significantly from what it was, and now the insurance are actually paying for the studies, which was important. In the past it was very difficult, but now it's definitely easier. And now we have supportive guidelines for the chest pain guidelines have been very useful too. So we just felt that during the process of us working on the manuscript, there was a lot of changes happening as well. Which is, I'm sure, something that when you're working on documents like that, and Dan has experience of that a lot, and then Arjun as well. I think you notice that you're always trying to catch up with the wave, but I feel that what we could do is kind of summarize the best we could what was available and the potential applications of the current technology, and that's basically how it came to fruition. It's just the interest of people driving really the process of having some guidance to utilize CT.
Yeah, Juan, this is great discussion, and I think that the document about CT imaging is really important, and you actually covered a number of issues. But I think the place where it really became very important is, the patients that we're seeing in the cardio-oncology space have many CT scans or PET CT scans, and so you have lots of imaging that's obtained, to look for cancer. And there was so many ancillary findings that, we use those findings to make decisions. And so I think having this guideline is very timely, because it does, kind of give us an update on how things are hopefully going to be quantitated in the future. But then the other piece, even in the general cardiology world, the use of CT for the evaluation of chest pain is really so much more effective than nuclear imaging for non-invasive measurements of ischemia, at least in my opinion. So I don't know. I think it was kind of one of those, perfect storm sort of situations where clinically we were using those CT images to make decisions and to really focus how we can analyze the available images in the best way. I think is so important. So I really applaud your efforts to pull that together. I wondered, how do you think your document would help people make decisions in practice in cardio-oncology?
No, thank you, Dan. That's a great question, and thank you for being so kind. So basically, I think that the main point is that, like when you look at the document from what is the from different documents. I mean, this is not only but there's a lot of documents providing recommendations about using the ASCVD, the ABCD, and doing all that. And I think that like you said, it's kind of in this day and age, it's kind of silly to just do that and not consider what is the imaging that is available, right? So that's why we kind of focus and to make the recommendations very clinical and in alignment with what we know that happened in the general population, and the calcium, the CAC, or the coronary artery calcium score, and knowing what we know, and knowing about the MESA, the strong, MESA studies that have been, leading us into understand that the burden of calcium is very important because it can definitely re-stratify your patient, even if you are in a gray zone where you're not sure if it's, a patient that have a higher risk, which is, a big problem of our practice is that we're dealing with a lot of patients that might be in the gray zone, that you might be intermediate, maybe higher, and calcium score is good for that. So basically, the practicality of it is that when you look at the recommendation provided there's a flow chart in the guideline that tells you about if there's a patient that does not have prior history of atherosclerosis, and then basically after doing your risk assessment, if it's in the intermediate range, then it's worthwhile. I would say it's worthwhile to look at every scan, of it doesn't matter what the risk of the patient is, but I think it's worthwhile to dig a little bit deeper and look at that scan if it's in the intermediate risk, because then you can re-stratify that patient and start them promptly on preventive therapy. And I think one of the things that allows you is to make a decision that same initial day that you're looking at the patient, because you don't have to order a test. Is if you have it there, you have it there. You can make decisions and determine that the patient has atherosclerosis just by looking at a non-contrast scan or a scan with contrast that you can certainly see some evidence of plaque there. So if you're able to do that, you can qualitatively assess the calcium based on the CAC-DRS, which is a method recommended by SCCT that you can do it qualitatively or quantitatively. So, and qualitatively can be, that's a lot of calcium, that's severe, or moderate, mild. There's some examples that the SCCT documents provide, but I think that, starting someone promptly on statins, I think that makes a big difference. And we don't have to think about the zebras or things that are, less frequent, like, for example, immune checkpoint inhibitor myocarditis. We know it's happened. We know it happens. We know it's more common than they said in the clinical trials, but it's in most patients, nothing is going to happen. But we know that atherosclerosis progression in immune checkpoint inhibitor, that's a hot topic in the field that is being, looked at very seriously by good colleagues, and we know that will be a problem too. So I think that the mitigation of the risk with any early intervention that we could do can make a difference. And I think our guideline, our consensus statement really supports that thinking.
Yeah, I think the other point you mentioned about statins, of course, but just the idea that if you identify underlying vascular disease, whether it's in the coronaries or in the peripheral vessels, that you're going to add antiplatelet therapy, perhaps aspirin or even Plavix, depending on the severity. But so it's you're utilizing images that have already been obtained, and you're looking at all the information that you can get from it, and then you're changing the therapy. So it's not like you're just looking at a picture, you actually have an action point. So I think that this is what's really important, because, we were sort of identifying this process when we did the radiation document, where everybody was getting a planning CT, for their radiation therapy, say in the pelvis, like for prostate cancer. And, there would be extensive peripheral vascular disease noted on the scan, but that didn't alter any of the therapy. So I think that looking at these images and appreciating the extent of atherosclerosis is really a critical point. And Arjun, I don't know what you think about all these things that we've been talking about.
Yeah, no, I mean, I think it's really interesting the way Juan mentioned in terms of, the genesis of the project, the fact that a lot of these patients, all the patients really have staging CT scans, and that's, the starting point. And I think, this is something that a lot of us, have thought about and have published on. And it's great to have the consensus document from Juan and colleagues and ICOS together to really just give us a very nice kind of grounding in the area. And maybe I could probably just ask Juan something specific about some different types of, patient groups. Like, we know with 5-FU therapy, a lot of the patients can develop some form of cardiotoxicity, be it cardiac spasm or chest pain of some description. I don't know, Juan, what you feel from the consensus document. How should we be assessing these patients with CT?
Thank you, Arjun. Great to see you virtually. Hopefully, we'll see each other at a CMR.
Absolutely.
But basically, thank you for your questions. I mean, I think that the important part, when you look at the different options that you have, if you have a patient that have an ischemic etiology of a clinical presentation, I mean, let's say. Because some of these patients, someone could argue like, oh, they're having ST elevation, they should go to the cath lab, and it's hard to argue, when you have dynamic EKG changes that someone will not head to the cath lab. However, as we have patients and we have patients. There's patients that you will send to the cath lab, and there's patients that you will say, you know what, I think we should do some sort of other test. Because the cath lab might not be a good option for these patients, but especially if their platelets count is pretty low, or they have some sort of other morbidity that in the general population, that won't be a conversation to have, but in our reality is different. So I think that in someone that had a very typical classical 5-FU vasospasm that resolved, and that we are, pretty sure about that, I think CCTA is a great option. Certainly someone that will be more of a clinical picture that is a bit uncertain when the symptoms started, what happened. I think those will require definitely, a higher scrutiny in regards to invasive assessment. And but I agree with you that some of our patients, the ones that receive a 5-FU, and the ones that, like anything in life, we have to be like, I think the clinical acumen that we have, in combination with the recommendations that experts give or the data or guidelines give, I think that the important thing here is, like, if someone has cardiotoxicity, and you see that the ejection fraction drop very close when they receive the anthracycline, or even within a year, and it's a non-ischemic presentation, right? Someone that basically comes with heart failure, and someone that is not certainly, very sick, in their clinical presentation, that will be someone, and when it's not clear, meaning, that you have an EF of 30%, but there's no clarity whether this is related to anthracycline, I think you have to exclude coronary artery disease. But I would say probably in someone 30 years old with sarcoma that got anthracycline, ejection with no risk factors, ejection fraction drop, 2 to 3 weeks after administration, I think that will be someone that will probably, you could monitor with echo and start prompt, heart failure therapy. You might not need to do a CCTA on that particular patient. I think it's just depend on the risk of the patient. So I'm not arguing that you should do a CCTA on everyone that is getting a cardiotoxic medication. I believe that that's, inappropriate. And our document, when we build the table, there's a table that talks about cardiotoxicity and when CCTA can be utilized. The message is not to get a CCTA on all those patients getting those treatments, but when there's a clinical concern, this will be an appropriate indication. But I think that that's basically might take in regards to cardiotoxicity. When there's a clinical uncertainty in regards to whether it's ischemic or not, because if you think about it, there's a lot of patients that are on anthracycline that the ejection fraction drops from 60 to 53%. What that patient needs is prompt medical heart failure medical treatment and not need anything else. And probably follow-up echoes definitely will be helpful, discussions about what to do next. And, I think that those will be appropriate things to do, but that patient likely will not benefit from a CCTA.
Sure, that's a very kind of nice way to just suggest that it's the appropriate test for the appropriate patient, and that's really the kind of what your consensus document is stating. And do you think you talked about the anthracyclines, but is there any role for myocardial assessment using a CT, and or is that, do you think, more for kind of research purposes or the next iteration of the document?
No, I think you're right. I think we didn't talk too much about perfusion imaging. We didn't talk too much, about the AI quantification of plaque, because we felt like in the current state, let our colleagues do the work, and let and collaborators and let's just them figure out what the data does. So when we go next time and evaluate the data, if there's some support of doing that or doing the ECV for CT, but or the problem with the ECV is that in MR, as ECV has limited applications. Certainly, I think in amyloid definitely. But in us, I'm not sure in CT that how things are gonna look. When you think about ECV, but I think that certainly that could be a consideration. But I feel like there's other when you get to subtleties about all these things that people are doing, I think that I will say, most of them don't really pass the filter of, what you consider clinically relevant for the patient. And it's the nature of the science. You just have, people have to keep looking at it. It's significant, not significant. I think that what we want to make sure is that we integrate in our clinical practice robust robust techniques that will, change your clinical either assessment, management, like change something for the patient. I do believe that CT has that potential in our population, and MR as well. I think both techniques are. I don't have to tell you because you have a lot of experience, in your program, very mature program. But you understand that, I think that unfortunately many places don't have access to CT and MR. Like we're just thinking about, developed nations, but when you talk to people in different countries, they don't have the same access. So you say, how can we help them, in regards to, it gets more complicated as you try to have a broader scope of the situation. But I think, it is definitely all these things are, something that we have to consider, certainly. But I don't think our role is to include everything that everyone is doing to say, how we apply this or how we apply that. But our role is to see what will be of benefit to immediate benefit right now, for our patients. So that's basically my take on all those things. I think there's a lot of great things going on, but there's, very few things are really, like game changers. If you know what I mean, like Entresto, that's a game changer. You have all these, things that the guidelines have to change around them because the data is undeniable. But I think with imaging, it's a little bit harder. And I think part of it is the way we do, the studies, the clinical trials. If you see now with CT, there's so much evidence randomized clinical data evidence that it really works, in stratifying. But we don't have the same, as robust, the same data for nuclear, and it's just because, the leaders from the CT world, they figure out we just have to make sure that we compare to standard of care, and we need to be above standard of care, and I think that that's what they have been able to prove.
Yeah, I think the other, the real challenge, kind of beyond what I mentioned before, where, you have a CT image, whether it's a coronary CTA, where it's, time to the cycle, and you can have very specific measurements, but even just a regular non synchronized CT, to give you a screen for whether there's significant vascular disease, having that is available anywhere that patients are being evaluated for cancer, because CTs are being done, and, so you can learn from those CTs and then apply it to your practice. So in that setting, you don't have to have super advanced imaging to be able to do the most sophisticated measurements. So I think there is a general application to a wide variety of practices in the world. And so that's one of the main points that I would say. But the other big challenge that I think we see this in everything, certainly cardiology wise, but, you have like the cardio-oncology guidelines, a massive document, has all this great information, but how do you get that to be utilized in practice? How do you get people to understand the nature behind the document, and then how to utilize that in a day-to-day situation? So with that challenge in mind, how do you think your document could address some of the day-to-day challenges that exist for our cardio-oncology patients?
No, absolutely. No, thank you. I think that, like you said, the day-to-day challenges, we have many of them. One of the challenges is the timeline. The patient comes to you, and you don't know anything about this patient. The first time you're seeing someone, wants you to assess them for X, Y, and Z high risk, treatment or whatever it is that the patient is having, and having the availability to, make decisions that first day of encounter without having, sometimes in many cancer centers, this is something that maybe in other practices is not big of an issue. But when I was in MD Anderson, the patient will come to you and there's no lipid panel. And you're seeing the patient, you need to make decisions or whatever. So, but you have the scan, so, or you might have access to, point of care labs or whatever it is. But I think that the ability to make decisions on that same day for the patient, I believe, although, I would say there's no randomized data on this, but I believe that if someone has atherosclerosis, a significant burden of atherosclerosis, that if you start on statins, you're going to decrease the events, but that applies to the general population. But for these unique patients, certainly I think that's really a game changer, that you can start and prevent, problems. Now, for the implementation part, part of what we wanted to do is to, in our document, we recommend that the radiologist or the nuclear medicine doctors that are reading these scans, they should report presence or absence of calcification in the coronaries. At least that, because if for the oncologist, when they read the report, if they see that the patient have calcified coronaries, they don't have to do anything else other than ask for help. Hey, my patient has calcification in the coronaries. Can you, and ask for expertise. Cardio-oncologists can actually see this patient, and evaluate that aspect of the patient, make sure they don't have symptoms, make sure they're optimal for treatment, and can answer this question quickly, so we're not delaying care. The issue here, and the impression some people have, is that we're going to tell, no, you cannot get the treatment. No, we're not here for that. We're here to mitigate. We're not here to say no. If the oncologist made the decision and they feel this is the drug for you, that's a way complex decision that is outside our realm of subspecialty. We're not there to treat cancer. We're there to support the treatment of cancer. So I think that having that ability to start something and having a good evaluation of that patient that came to your door, I think makes a big difference. And perhaps in some other practices, the patient has to come back again after all this testing, whether, you could probably expedite some of this risk stratification by using the tools that you have available. And you're right. I think the calcium score is something that even, in communities or in countries where there's some limitations, that's something that certainly there's some scans that they're going to do for, to look for the cancer. So they could just look at that and get some a better assessment. So I completely agree with that. The other piece of how you implement documents, at least our experience has been that, because we involved radiation oncologists as well. I mean, because and we had also Susan then was part of this document, and I felt like she is an important stakeholder, because she is basically, in like the link between cardiology and and oncology, and we also had radiation oncologist, a collaborator. Her name is Sarah Milgram, which she's involved also in Astro, and we were able to approach Astro and we seek their endorsement, because we felt like if Astro endorses this is going to be a document that is going to have some direct consequences to the radiation oncologists. Initially, they decided not to endorse the document because they felt that we were pretty mature in the development, and they felt like they wanted to have someone from the get-go, which is standard for all societies. I definitely understand that, but they did wrote a document, a manuscript that came out recently. It's like a review article on their journal from Astro, discussing the implications and summarizing this document. So this SCCT ICOS document now have a leg. I want to think about, there's a leg in Astro where there's people that are aware of this document, and we are reaching new audiences because this document has been supported, not endorsed, but I think this is a kind of like a support that they feel that what we're saying applies to them and is important and relevant.
Yeah, so Arjun,
good.
Arjun, I just wanted to see what your thoughts were on your practice patterns in the UK. I mean, do you consistently review CTs for these types of findings, or do you have some sort of software to do the calcium score and those types of things, or just go with the basic CT?
Yeah, no, thanks, Dan. I think it's a very interesting point, and this is something that we were looking at even before the consensus document came out, because I think, as Juan mentioned at the very beginning, this really probably has stared many people in the face that they're having CTs. You can see the heart in all of them. Why don't we have a look? So I think the beauty of Juan's document is that it's now kind of being crystallized that this is something that you should be looking at, and then that's something that the radiologists can also take on board. But I think it's a fantastic document, and really my take-home message from what I understood from Juan is we should be using the test appropriately in the appropriate patient. No overuse, no underuse, but maybe appropriate widespread use in across the world. I think maybe to wrap up, that would be the statement. But I don't know, Juan, as the final statement, what would you say is the take-home message from your wonderful document?
Thank you, Arjun, for those kind words. I think that for me, when I go, when I'm seeing a patient and I open it, sometimes because I don't remember everything. It's hard. It's a collaboration. I have to remind myself, okay, let me see what was the consensus here or there. I think that what enables us is to utilize appropriately, and make sure that we're risk stratifying that patient, as quick as we can. Cardio-oncology is about timeline. The patient, is going to start radiation therapy here. They're going to start chemo this day. So any delay, unlike other situations that we deal as cardiologists, as general cardiologists, where there's certainly some things that can wait, or some people that refer you patients that say, hey, I'm just waiting on you to, so that patient can wait and you can work up. And sometimes you just have to tell your referring colleagues, what, I need some time to deal with this because this is more complicated, and we need to make sure there's X, Y, and Z done. So I think that for that patient that is an urgent timeline, I think this document helps in stratify. Additionally, other than using the ASCVD risk score, like let's say if your risk score is 0, but you see a lot of calcium, there's a problem, and there's discrepancies. There is certainly discrepancies between ASCVD risk, like the fact that you have a low ASCVD calculated risk doesn't mean that you don't have atherosclerosis. Those are two different, things. One is the risk of something happening, which is something that is done on a population basis, assessment. And the other thing is the personalized approach, which in oncology, the way they practice is by using the personalized approach, looking at what genes, what is the biomarkers that will respond likely better to this therapy. We're not doing that. I think that's the next, evolution of cardiology is going to be personalized medicine. So, if you ask me in the future, I see a lot of AI plaque quantification. I see more of that, approaches, because I think that certainly if you want to, palliate the situation on a populational based approach, then you use the risk score. But if you want to make a difference for each single individual, I think we have to start thinking about personalized medicine and what works better for the individual. And that's something that is going to take many years because it requires a lot of data. But I think that's the approach that in oncology has worked wonderfully. Look at how they have changed the overall survival, just by personalizing the treatment and not just giving chemo to everyone. So I think that for me, the take-home message for this document is, to be practical in the approach, be prompt, look at those scans, look at the calcium. If there's calcium, you have to act on it and not ignore it, not just look at the patient, get the story, we'll get the lipid panel, we'll get this, we'll get that. You actually can risk stratify that same day.
Well, Juan, thank you so much for your time today. You said there aren't many game changers in cardio-oncology, but I think this consensus statement seems to be a game changer. So we really appreciate the great work that you're doing. We appreciate the collaboration with ICOS, and we look forward to hearing more from you in the future. Hope we can speak with you again before too long. Thanks for joining us today.
Definitely. Thank you. Appreciate your invitation. Thank you.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.